Hi, everyone. Good afternoon and welcome to ILD Day. I am Amy Hajari Case. I'm the Chief Medical Officer at the Pulmonary Fibrosis Foundation, and I am so glad that you've all joined us today. Our ILD Day webinar happens every year during Pulmonary Fibrosis Awareness Month in September and is hosted today by 13 partner organizations. If you could hit that next slide, please. So I'd like to just extend my thanks as we're getting started to our partners, the Arthritis Foundation, the Foundation for Sarcoidosis Research, the Myositis Association, the Myositis Clinical Trial Consortium, Nori's Fight, PF Warriors, the Scleroderma Foundation, the Scleroderma Foundation of Greater Chicago, the Scleroderma Research Foundation, the Sjogren's Foundation, Team Telomere, and the Wesco Foundation for Pulmonary Fibrosis. Before I introduce our guest speaker today, I want to go over a few housekeeping items. First, we would love to answer your questions during our Q&A session at the end of the talk. So if you will, when you have a question to submit, please navigate to the Q&A button on your control panel, probably at the bottom of your screen, and submit your questions there as you think of them, and we'll do our best to answer as many as possible. You can also communicate with our team about any technical questions on the Zoom platform through the Q&A button. If you would like to turn on captioning for our webinar today, you can locate that also on your control panel. It may say captions, it may be hidden under three little dots for a more button, and then you can turn the captions on that way. We will be sharing a downloadable version of the slides for today's talk in your Zoom chat. So when you see that pop up, it will be located on your control panel in the chat button, and you can download those in PDF. At the end of our session today, you'll have the opportunity to give us feedback, so please stay a moment and let us hear from you about our session and about our webinar series and what you would like to hear from us in the future. And finally, if you could hit that next slide for me, please know that the information that we share today is really only educational in nature and cannot substitute for personal medical advice. So we're unable to address questions about your medical situation and care, and I would encourage you to discuss any questions of that nature with your personal physician. And now I have the privilege of introducing Dr. Scott Matson. Dr. Matson studied medicine at the University of Kansas School of Medicine, then did his residency in internal medicine. It was a chief medical resident at the University of Colorado in Denver. He completed his pulmonary and critical care fellowship at the University of Colorado and National Jewish, where he pursued advanced clinical and research training in interstitial lung disease. He is now on faculty at the University of Kansas, and Dr. Matson sees patients in the interstitial lung disease and rare lung disease clinics, as well as attending in the medical intensive care unit, and serves as associate program director for their pulmonary critical care fellowship and directs the fellowship research program. He's a clinician scientist whose research lab has received funding from the NIH, NHLBI, NIGMS, the American Lung Association, the Pulmonary Fibrosis Foundation, and the Rheumatology Research Foundation. The Matson Lab leverages systems biology and quantitative imaging analysis to develop treatment prediction tools to better understand the role of immunosuppression across etiologies of interstitial lung disease. In 2024, Dr. Matson founded and now directs the Kansas University Medical Center, Autoimmune Lung Disease Clinic, a joint effort between pulmonary and rheumatology divisions at KU that manages complex patients in the region and serves as a hub for clinical trials and research efforts for these patients. Welcome, Dr. Matson. Thank you so much for being here today.
Thanks so much. Thanks so much to the Pulmonary Fibrosis Foundation and to Dr. Hajari Case for this invitation. I'm really excited to be here today and talk about a topic that's near and dear to me, which is pulmonary fibrosis, what we know about this condition, what we don't know, and what the future may hold. So Dr. Hajari Case was very gracious with that introduction, but aside from my day job, I'm also a father to these two little chaos agents, a 4 and a 6-year-old, a first grader, and a pre-K. My wife is a pediatric cardiologist here in Kansas City at the Children's Hospital, and our nights are much busier than the days, even though we both have fairly busy day jobs. So I'm excited to be here today And what I want to talk about at first is just a little bit of a primer about how genes work in the development of human disease. Just to try to get everybody here on the same page about what we know about human disease development in terms of genetics and what a genetic disease is, what genetic risk is. So, genetics really can sort of is a short primer for many components of the biologic system. And really what we're talking about is the blueprint for much of what happens biologically, and then what happens downstream of that when things don't go right and how that leads to human disease. And genes really implicate sort of regions of DNA. And DNA is, of course, the blueprint, the sort of book for instructions for the building of all the machinery that are required in a biologic system to, be a human. Um, Genes live inside of these packages called chromosomes. And even at all of our very earliest developmental stages, when we were just a couple of cells, all of the DNA information that we contain now existed within those initial few cells wrapped up in a chromosome. And all of the information contained in those chromosomes was all the information the system and the cells needed to go from those few cells to becoming a human, to becoming a baby, and then growing into an adult. And what each of these DNA regions, called a gene, encodes is different. And they can be turned on, they can be turned off. And in human disease, what happens is that typically, in a few different circumstances, and we'll discuss all these throughout the rest of this talk, there are cases where something goes wrong in the gene that's transmitted from the parent to the child. And in some cases, what's happening is that parents may carry a carrier gene, and they may carry copies. We'll have some diagrams for this later, but in some cases, the parents pass a genetic condition directly on to the child, such that that gene is encoding for some abnormal product that leads downstream to human disease. So in some cases, even at that first cellular level, the fate is sealed, and there's going to be some disease process as a result of what the DNA code looks like. Those are the sort of classic heritable genetic diseases. And what that means is that right away, on day one, when that baby comes out, we can test for these diseases. And we know immediately, because of a dysfunction of a gene and what it encodes, that that baby is going to have that disease phenotype, and it's going to grow on and manifest that disease. In some cases, given whatever function may be perturbed, they may manifest some of that right away clinically. In some cases, it may be a short period of time in early childhood when they start to manifest those diseases. But in general, it's something that we know. They're born with a genetic abnormality that leads to disease and a phenotype right away. And then there's the more complex nature of most chronic diseases, which is the genes play a role, but they don't play that kind of direct role. There's not some specific gene abnormality that encodes for something abnormal such that that biologic system won't function normally. But instead, that gene, and in most cases, many genes actually, generate a risk, which is to say that people are born with many risks for many chronic diseases. And because human experience is so diverse, it often is true that time and then subsequent environmental impacts of where somebody lives, what kind of job somebody has, what kind of hobbies somebody has, the kind of uh, toxins that they may consume, like cigarette smoking. All of these environmental factors then get mixed with time, and then combined with this genetic risk is what leads to many chronic diseases. And so we'll talk about how this is important in pulmonary fibrosis as we move forward. But I just want to try to get this basic biologic dogma down so that we all have sort of this shared model as we move through this talk about pulmonary fibrosis. We're born with DNA, which is a blueprint. It's sort of a book that reads out so that the machinery of the system can read that instruction and then make whatever protein or enzyme is required to do the job. And sometimes genes are turned on. Not all these books are being read at all times. And so there's a bunch of systems in place to make sure that we only need the books when we need them, and that as long as they're reading appropriately, then the biologic system should go on and function normally. And that's the way things work normally. And then we'll talk a little bit about how that's perturbed and what that implies for our understanding of pulmonary fibrosis in the rest of this chat. So if we take one step back and just think about pulmonary fibrosis specifically, pulmonary fibrosis occurs across many different causes or etiologies. And depending on which textbook you choose to open, it's true that probably there are about 200 different etiologies or more of things that have been associated with the development of pulmonary fibrosis. So uh, there are many, many known causes of risks and diseases that increase the risk for pulmonary fibrosis. But, clinically, as a clinician, when I see patients in clinic, and I think this is true for most people, largely, I think what we're trying to do based on understanding the patient in front of us in terms of their personal history, the diseases and comorbidities they have, and the kinds of exposures they have, is to try to put patients who have pulmonary fibrosis into one of these three sort of big buckets. And the three buckets that I think about when I'm framing this are those patients who have an idiopathic disease. And that's what I've sort of labeled here with a quote unquote genetic diseases. And we'll talk about some of the discoveries that have been made in the last 20 years, but really, until the last 20 years, we did not think of these idiopathic diseases as having an underlying genetic risk. And we've learned a lot about that in the last few decades. But in general, these are the group of conditions for which we can find no other underlying systemic disease that increases the risk for pulmonary fibrosis, and patients where we can identify no ongoing exposure to something that increases the risk for scarring in the lung. And when we've excluded those other possibilities and we identify no other identifiable cause that we can remove or a systemic disease that we might be able to treat, we're left with the idiopathic versions of these diseases, which is the largest bucket of patients that we see in clinic. In many cases, about 60% of patients that present to an ILD clinic end up with an idiopathic disease. Now, again, we'll talk about some of the studies that have given us insight into the genetic underpinnings of these diseases, but globally in clinic, these are the ones I sort of describe as this is the disease that somebody had a genetic risk for, and then there are several environmental factors that increase the risk, but in general, that bucket of diseases is the first bucket. And then there's these two others, right? And so what we know about pulmonary fibrosis in humans is that in many cases, patients have repeated exposures to antigens, something in their environment that they inhale into the lung that leads to this recurrent cycle of lung injury, inflammation, and then eventually scarring. And in the US, one of the most common causes for this, interestingly, is people who have birds in the home. It's called avian hypersensitivity pneumonitis. But in that case, there's people who are repeatedly exposed to the protein content that lives on the feathers of flighted birds, and they inhale that because it's in their environment. And for some people who have this underlying risk, that exposure to that repeat antigen leads to this, inflammatory injury fibrosis cycle in the lung that repeats until somebody develops clinically meaningful pulmonary fibrosis. Now, within these environmentally mediated bucket, there's sort of these two subcategories. There's this organic. So I think of that as like the birds or like people who are exposed to standing water in their home, whether it be a swamp cooler or an indoor sauna or previous mold damage, a mold or an amoeba-like substance that grows there that's inhaled. And again, that can lead to that same cycle in the lung. And then there are people who have environmental jobs mostly that are inorganic particulate matter. So people who work with asbestos or sandblasters who work with silicosis, these very small, fine particulate matters get aerosolized, they get into the air, and they get breathed deep into the lung, and they're so small that they get all the way down to the distal part of that lung, and that's not supposed to be there. And so for some of these people, that repeated exposure of those kinds of inorganic particulate matter leads to that same cycle of injury, inflammation, and then scarring. And then the third bucket of conditions that we see that leads to pulmonary fibrosis are autoimmune interstitial lung diseases. And these are people who have a systemic autoimmune disease that causes, many full body symptoms, joint pain, skin thickening, inflammation of the salivary glands. These are patients who may have already have an underlying diagnosis, so they've previously been diagnosed with rheumatoid arthritis and then they develop a pulmonary fibrosis. Or in some cases, we only identify that systemic autoimmune disease when they develop the interstitial lung disease. The lung disease may come first in about 20% of these cases. But what's true across these populations is that if you look at populations of patients who have, for instance, scleroderma, a systemic autoimmune disease and you screen that population for the presence of interstitial lung disease, we see it in a really high rate, about 40%. And for populations like rheumatoid arthritis, it's lower, but it's still very high. It's about a quarter of patients that have abnormalities on their CT scans. And about half of those, in general, we think go on to manifest clinical disease. So these are the three buckets that we think about, and we've sort of put quotes around that first one as sort of the classic, sort of what we think of as a genetic disease. But what's interesting, if you think about and hear the way I've described these conditions, is, what it takes is the environmental exposure. What it takes is a systemic autoimmune disease. But it's true that there are people who have those exposures and people who have those systemic diseases that don't go on to manifest a pulmonary fibrosis. And so even though scleroderma, about 40% of those patients have ILD, 60% don't. And even though about 10% of rheumatoid arthritis patients develop a really meaningful and significant pulmonary fibrosis, 90% don't. And the number of times I've been in clinic and identified somebody who had a bird in their home that was likely causing a lung injury, they usually live with other people. And the other people that they live with in the same bird, in the same environment, their spouses and children, have no symptoms and have normal CT scans and have no manifestations of this kind of response. So what's true, I think, independent of which one of these three buckets a patient ends up in, is that there's an underlying risk that a patient has to have throughout their lifespan such that these second hits, whether it be the bird or the asbestosis or the autoimmune disease, when that occurs in the person who has an underlying genetic risk for pulmonary fibrosis and interstitial lung disease, that is the thing that sets off that patient down that path of developing interstitial lung disease. And it's true not just in that biologic understanding of some people have it and some people don't, even though they have the same disease. It's also true that when we've looked across populations of these other conditions, like hypersensitivity pneumonitis or like rheumatoid arthritis, interstitial lung disease, it's true that if we look at what is the largest risk factor for the development of interstitial lung disease in those populations, it's not just the smoking and it's not just the age and it's not just the gender. It's the shared genetic risk. It's the same genetic risk that we see for those idiopathic diseases that is the greatest risk factor for the development of interstitial lung disease and pulmonary fibrosis across etiologies. So I think you could think about these really as an underlying risk that many people in the population have. And then there's some second and third hit that occurs in combination with time such that the repeated exposure and repeated injury and repeated inflammation leads to more and more scarring, such that really this is almost always a combination of a risk, which I think many people are born with, and then, the things we can and cannot control about our environment that add up over time. I mentioned before that there's a shared risk, and we'll talk a little bit about this specifically, but it's probably something people have heard about before if they've been interested in this topic, which is this MUC5B. So let's talk about what that is. So this is that most common genetic risk that we've identified across those idiopathic diseases. It's the one that's shared across those others, those environmental exposures and those autoimmune diseases. And like most conditions, we learn a lot about the underlying genetics of the disease from populations and families, or families from families that have, a familial form of these diseases. And so pulmonary fibrosis is not dissimilar to many other conditions where we learn a lot about the overall condition by initially studying those groups of families that cluster. Because many diseases are like pulmonary fibrosis, where there is a shared genetic risk that's really strong in some families, but that's shared across the population such that we can see a combination of a familial cluster of patients and then these more sporadic cases that make up a majority. And we'll talk more about familial versus sporadic later. But from those initial probands of families that had familial pulmonary fibrosis, the David Schwartz lab and investigators studied the genetic differences in those families compared to healthy controls. And then they extended those observations to sporadic causes, meaning people who have IPF that don't have family members that are diseased with pulmonary fibrosis. And they found that there was a shared genetic risk. So if you take 100 people that have pulmonary fibrosis and you look at all the things that we know about their clinical risks, their environmental risks, and then looking at all of the genes that we can map in that individual and say, what is the most important risk for driving pulmonary fibrosis that's shared across those families and that's shared across those patients with sporadic idiopathic pulmonary fibrosis? We find it's this promoter variant of MUC5B. And so what is that? Well, MUC5B is a gene name and a protein, and it stands for a mucin, which is an airway mucus protein. It's basically like snot. It's the gel-forming mucus that makes up, saliva and the schmutzy stuff in our airways, all the way from the nose and mouth all the way down into the lungs, one big shared continuous epithelium. And our airway mucus is made up of two proteins. One is MUC5B, and the other is another one called MUC5AC. And in general, there's a pretty fine balance of these two gel-forming mucus proteins that make our respiratory tract work normally. And if you think about what's supposed to happen in a human, we're breathing in our environment all the time, and we breathe in air and oxygen, but we also breathe in cologne and smoke and bird feather or whatever. And our lung is supposed to be able to basically take the air and the oxygen and do the normal things we do, and then get rid of all the other stuff that's not supposed to be in there. And our mucus plays an important role in that. It helps lubricate the environment to let stuff move freely in and out. And what's true is that the people who have this promoter variant, what happens genetically is that they've got something different in their gene signatures such that they make more of that mucus, that MUC5B mucus protein. They make more of it. Because if you think about a gene as a library book, it's not open all the time. We don't need mucus proteins made all the time. And so there's something called a promoter, which is basically a gene signature that gets turned on by various biologic systems that says, okay, time to open the book about mucus proteins and make more of it. And what happens in the promoter variant is that that book is just open a lot more. The promoter is on, it doesn't turn off. And when the promoter's on, it means we just make a lot more of this protein. Having more mucus in your protein, in your airway, because we have two of them, it's not the end of the world in the sense that some diseases, which are genetically mediated, they may alter a protein such that it just doesn't exist at all, right? And that's the kind of disease that typically manifests very early. If the protein that doesn't exist because of a gene abnormality plays an important biologic function, then you could imagine the absence of that protein plays a much more significant role than just making more of it, right? And so this is probably one of the reasons that pulmonary fibrosis takes decades to develop, is because this is a somewhat subtle abnormality where you've got two mucus proteins, one of them gets made in abundance, right? And what's true is that we know clearly that this is a risk. We know clearly that amongst people with pulmonary fibrosis, if we take any collection of people who have pulmonary fibrosis and say, look at all their blood and CT and all total history, this is going to continually be the most important risk for the development of that disease in that population. We still don't have a really clear link between this risk and why exactly pulmonary fibrosis develops. But I think there are hypotheses, right? One hypothesis is because we make more of this mucus protein over time, it builds up. And in the very small distal nooks and crannies of our lung where all the oxygen exchange is supposed to take place, it's probably a pretty fine orchestrated balance of that mucus. And it's supposed to be there to lubricate, to keep protective mechanisms of getting the bad stuff out of the lung. And you could imagine a world where if too much of that is there, it traps some of those bad guys down in the distal part of the lung. And so if you think back to the couple that has a bird in their home, you could imagine a world where the husband who has pulmonary fibrosis, he's been around that bird the same amount as the wife has, but the difference is he's got all of this, built up distal mucus in the lung that's been there slightly small over time, such that all that antigen from the bird feather gets down in there and gets trapped and just can't make its way out like it can in his wife. And that small, tiny difference may lead to these tiny little imperceptible inflammatory injurious injuries followed by fibrosis, such that the husband, 20 years after the bird arrives, has pulmonary fibrosis and the wife doesn't. And maybe it's mediated by this kind of mechanism. Now that's a hypothesis that people have put forward, and we don't know that, but we do know that the genetic risk is real, and we do know that that's what this gene encodes for, and we do know that that's the role of MUC5B. And I think the rest makes some sense, but there's a lot of gaps that still need to be filled in. Now, if we think about other genetic diseases, those that impact people earlier in life, when we think about the way those are inherited, one of the things that I think is important to note is that genes come from parents, and we are all born with two sets for each one of the genes that we have. And then in our offspring, they inherit one set from us and one set from our partner. And so in some of these diseases, and cystic fibrosis is a good example of this, you got to have both copies of the disease. This is what we call an autosomal recessive condition. And it's not that important to understand this, but basically some genetic diseases, you got to have two abnormal copies in order to manifest disease. And then there are some genetic diseases where you only need the one, which can be called autosomal dominant. And then there are some diseases like pulmonary fibrosis where it appears that the risk is true whether you have one or two, but it may be more risk with the two alleles. But again, it sort of highlights the idea that the difference between a condition like cystic fibrosis, where two gene copies are inherited from the parents, this baby with cystic fibrosis on the bottom far right, that's a person who is born with the absence of a functional protein because the gene doesn't work normally. So right away, immediately, on day one of that baby's life, we can screen for cystic fibrosis and identify it because there's abnormalities that are manifesting right away. And cystic fibrosis doesn't lead to a clinical phenotype on day one, but early childhood cystic fibrosis leads to differences that are clinically meaningful. But it's a genetic abnormality due to the loss of some function that the baby's born with. Whereas in pulmonary fibrosis, what we have is an overexpression of a protein, and that overexpression probably leads to these risks because of the additive effect of time and injury, and it usually requires some kind of other exposure on top of that. And that's true even in families that have pulmonary fibrosis. So even in familial pulmonary fibrosis, there are no children with pulmonary fibrosis at 5 years old as a result of the familial disease. Now, there is a whole host of childhood interstitial lung diseases, but that's a different condition than what we're talking about today. But what's true about even families who share a risk and multiple generations have it, right? And the way that we classify familial pulmonary fibrosis is someone who has pulmonary fibrosis and has at least two first-degree relatives that have the same kind of condition. And even in those settings where a brother and a father have familial pulmonary fibrosis, and now this person in front of us does, typically the patients don't present, even if they may present slightly earlier, it's still often in the 60s and 70s, just like the sporadic forms of this. And so even in this case, it's a genetic risk that the patient is born with, but it still requires time. And in many cases, it still requires some kind of other environmental insult. And it's true in families who share this risk that there are unaffected relatives. And this is just a slide that I probably should have advanced earlier, but this highlights that difference, right? So this highlights the difference between the kind of genetics that underlie pulmonary fibrosis versus the kind of genetics that underlie cystic fibrosis, which is to say that you're born with it, you have disease right away in a condition like cystic fibrosis. And with pulmonary fibrosis, you're born with the genetic risk, but the manifestations don't occur until decades later and may not occur in everybody who has it. What's true and what's important to think about with even MUC5B is that if we screen the general population, it's what we call a high penetrance allele, meaning a lot of people walking around have that risk. Some estimations are as much as 10% of the population. But clearly, that is not the incidence of pulmonary fibrosis. And I think everybody on this call understands that pulmonary fibrosis is more common than I think it's, popularity in the zeitgeist. There's a lot of this disease and a lot of people working really hard to treat and understand it. But it's also true that it's not as common as that, it's not a 10% common disease. And so even though this is a high risk, and if you look across people that have pulmonary fibrosis, MUC5B promoter variant polymorphism is going to be incredibly common. If you take everybody that has MUC5B, pulmonary fibrosis is still incredibly rare across the people who have that risk. And I'm happy to talk more about that because that's kind of an interesting and an interesting concept to think about when we think about risk for this condition. So now, the difference again between familial kinds of diseases and sporadic diseases is that by definition, a sporadic disease is someone who has, in this case, pulmonary fibrosis, and they're the first person essentially in their family to have it. And again, even in those sporadic cases, we see similar genetic risks to what we see in familial cases. But again, as I've sort of highlighted already, one of the major differences between this condition, even a familial pulmonary fibrosis, and other sort of more commonly genetic diseases is how quickly they develop. And that's largely because of the nature of what the gene is doing. Even if genes are inherited the exact same way, if the gene encodes for too much of a protein, like in this case, that's a different risk profile than the absence of a protein like we see in something like cystic fibrosis. So what does this mean clinically, and how do we take these kinds of genetic insights and what do we know about what does that teach us as clinicians and as scientists and as patients and as people who care for people who have these conditions? What can we learn from this and what does it mean for the management of this population? Um, what I would say is this is one of the fundamental ways we go about understanding diseases in order to derive better treatments. So one of the reasons I've been highlighting cystic fibrosis is um, many people on this call are probably aware, but one of the really groundbreaking breakthrough medical treatments, really, I think in the last several decades, has been advances made in the management of cystic fibrosis. Um, really in the last 5 to 10 years, uh, effective modulators of the CFTR, the cystic fibrosis channel that restores function to the protein that's genetically altered in that condition, have fundamentally changed the condition of cystic fibrosis from the kind of thing that leads to a loss of 60 years of life for most people to the kind of thing that may be a chronic disease that can be managed through a normal lifespan now. And there are babies being born today who have cystic fibrosis that are going to go on these modulators that may be able to live a totally normal life now. And that is an enormous and important clinical breakthrough. And that came about because of the understanding of what the genetic abnormality does and how that manifests in clinical disease. So cystic fibrosis is an interesting corollary to pulmonary fibrosis. In cystic fibrosis, there's alteration in a channel that transmits sodium in most cases into that mucus layer in the lung and in other organs. And that plays an important role in keeping that mucus layer in the lung functioning normally. And in the absence of that channel function, the mucus becomes thick and non-functional. And again, the absence of function versus a gain of function, like pulmonary fibrosis, in the absence of the function of that channel, the mucus basically doesn't work. And instead of functioning differently, like in idiopathic pulmonary fibrosis, in cystic fibrosis, doesn't work at all. And that leads to loss of lung function and importantly, just chronic infection because instead of having a safe layer of mucus to help move bad stuff out of the lung, instead it all just stays down in there and becomes infection. And for years, the only way to manage the patients with cystic fibrosis was to just treat infections as they occurred and then to try to help cough up schmutz. And it was a pretty non elegant treatment mechanism. But through the understanding of what genetically is altered in cystic fibrosis, through understanding what that channel did, and through understanding that the mucus layer didn't work, and as a result, the little hairs in the lung called cilia that help move all that stuff out of the lung, they just didn't work. They didn't beat in cystic fibrosis. Through understanding all of that, which went back to the genetic basis of the disease, investigators were able to make a model for the disease, right? A model is basically what a scientist uses to try to recapitulate a human disease in a lab so that they can try new treatments and try to change things about the system so that we can see if we can improve it. And fundamentally, it is essentially impossible to make a breakthrough in therapy or treatment for a condition if you don't have a good model. And I think most people will tell you honestly that the model we have had for pulmonary fibrosis has been bad for a long time. And it's possible that in the last 20 years, with the insights we have made about the genetic risk of this condition, that we can actually start to refine a model like the CF investigators did to get to a place where we can potentially create treatments that can actually modify the disease and potentially reverse it. So that's one thing. I think right now we know genetic risk, which is really been housed in the realm of research papers, but I do think that there's a really potential fundamental important insight that could come from that, which could have downstream clinical implications, which could be the most important part of this story, in 20 years, is my hope. Maybe sooner. And then the second part is, what does that mean about the impact on family members? And and I want to just highlight a few things. So the other thing that we know right now is that people who have idiopathic pulmonary fibrosis, whether it's sporadic or familial, there's just a higher risk of pulmonary fibrosis globally in subsequent generations. And that's largely because genetic risk is shared across generations, of course. And one of the major differences between sporadic IPF and familial pulmonary fibrosis is not just that one genetic variant of MUC5B, but it's a host of other genetic risks for pulmonary fibrosis that are more commonly shared in the familial cases than in the sporadic cases. And one of the things that I do think highlights this, and again, maybe one of the future steps for how genetic understanding of this disease could influence clinical practice, is our understanding of the role of what's called a telomere in this story. So DNA is housed inside a chromosome. That's like the library that holds all the books. And we unspool parts of the chromosome to get to the DNA when we're ready to use it. But the protector of that chromosome is the cap that sits on the end called a telomere. And as our telomeres shorten, that shortens as we all age. And as they shorten, we all start to show signs of external aging. And we know that families who have pulmonary fibrosis not only share the MUC5B risk, but often share a mutation in a repair mechanism for these telomeres such that they become shorter earlier. And that can manifest in external signs of aging amongst these families, like early graying. And then it leads to other clinical manifestations aside from pulmonary scarring, like liver scarring. So these families can often have cryptogenic cirrhosis or scarring of the liver. And then often the bone marrow has a high turnover rate. And so bone marrow can also have a similar kind of loss of function through things like aplastic anemia and some leukemias and lymphoma. But interestingly, and this is one of the kind of work that our lab's interested in, is what can we learn about the biology of the condition that can tell us something about the way we should treat these patients? And I think this is a really interesting insight that comes from Chad Newton and his group looking at some data from IPF patients. So in the old days, we used to treat patients with IPF with immunomodulatory therapy, treatments that would suppress the immune system and suppress inflammation. And we had a seminal randomized trial in 2012 called the Panther study that exposed patients to placebo or that kind of immunomodulatory therapy. And unfortunately, we found that immunomodulatory therapy on the whole was associated with more harm. But what Chad Newton and his group was able to do was look at the group of patients who had the most harm. And what they found is that the patients who had the most harm were those with the shortest telomeres. So if you can see here in panel A, what we're looking at is a survival curve. And this is patients exposed to immune suppression in the red, patients exposed to placebo in the red. And you can see the closer you are to 100, that's 100% survival. So we want the lines to be as high, tight to 100 as we can. And you can see that the placebo group, while they do have death rates at 60 weeks down to about 70%, we can see that the blue line, which is those with the immunosuppression regimen of prednisone, azathioprine, and acetylcysteine, that's the group that has a much worse survival. So at 20 weeks, you can see it's about 40% compared to about 90%. So an absolute difference of 50% survival. And that was mediated entirely by these two groups that were divided by having long telomeres and having short telomeres. And the groups with the shortest telomeres seem to experience the most of the harm from that immune suppression regimen. So even though this is not clinically useful today, I do think this type of insight tells us that there's something biologically true about patients with pulmonary fibrosis that can tell us about how they're going to respond to treatments. And genetics, telomere length, and even some protein biomarkers that we're interested in, these are things that we might be able to use in the future to predict this and allow us to use drugs that are already being used in other human conditions in patients who have these kinds of conditions by identifying markers that we could potentially use to predict that kind of response. And then the final thing I'll say about this, and I'll leave time for questions now, is I really do think that we are on the cusp of potentially learning a lot about how we can potentially alter the natural history of this disease. And one of the ways that I think it makes a lot of sense for us as clinician scientists and clinicians to try to help alter the natural history of this disease is to identify people at risk early before they manifest the lung disease and use the treatments that we're using now earlier in the course. Most of the therapy we have for pulmonary fibrosis now slows progression, but still has progression. And so it makes, to me, a lot of biologic sense that the earlier you can start that therapy and the slower, the more you can intervene on progression before it happens, the longer you make that curve of progression, the more we have the possibility of changing this from a disease that you die of to a disease that you die with. And familial pulmonary fibrosis may be one of the first places where we can study this kind of approach. And the group that's leading this charge is Margaret Salisbury and Tim Blackwell at Vanderbilt, where for about a decade now, they've been screening family members of patients with pulmonary fibrosis. And so when they see somebody in clinic who has a familial pulmonary fibrosis, they invite all of the first degree relatives of that person to come to their research group to get CT scans and to get clinical information and samples collected. And then they follow those people over time. And this year they published one of their first reports of what happened to that group. So it's a prospective group. They find them at when they first meet them, and then they just continue to follow them to time points in the future. And importantly, they repeat imaging. And one of the things we've learned from this group and from this finding, which is, I think, not shocking, but really, really important, is that the rates of progression of people with early changes on their CT scans who are within these families, the rates of progression are really high. And to me, what this says is we have an enriched population of people likely to get worse, who we know and can identify because we take care of their relatives, and that this might be a way to test what could be one of the most important, next steps of management in this condition, which is early use of treatment early in the disease course before somebody has symptoms and before they have clinical disease in order to try to delay that progression, to a meaningful time in the future. And so there's a lot to come. There's a lot of steps required to get us from where we sit now to where we need to go. But I do think there's a lot of work being done to try to understand how we can understand the genetics of this disease to help us understand progression and to create a better model of this disease. And then secondly, what I'm most excited about, which is potentially quicker, would be how we can use our understanding of genetics and biology in this group to use existing treatments to enrich it in populations that may benefit more. So I'll wrap up there, and I'll happy to take any questions for the time that we have left. And I really appreciate your attention. And thanks so much.
Thanks, Scott. This was such a great overview of a complicated, to say the least, topic. And it has certainly sparked a lot of interest and really interesting, thoughtful questions that I would love to try to get into as many as we can. If you are ready, we will go. Okay. Um, so talking, I'm gonna ask a few questions about very practical matters as someone who might be dealing with or be aware of ILD or pulmonary fibrosis in their family. So let's start with the person who has a single family member with a form of interstitial lung disease or pulmonary fibrosis. And we can say it's a first degree family member. For those of us out there, it's a parent, a child, a sibling who's affected, but no one else, we're not aware of anybody else. Would you recommend any action by that person if they're not experiencing symptoms or have known abnormalities on imaging or anything like that?
Yeah, that's a really good question. And I think it's an important one in that we don't really have, full empiric data to answer. My guess is that that person's risk is infinitesimally small for pulmonary fibrosis. And, picking somebody off the street and then comparing the risk of a person off the street to that first degree relative, there may be a very, very slightly higher risk in that first degree relative, but it's still incredibly small in terms of that person's personal risk. So there's a relative risk that may be higher compared to just Joe Blow off the street, but that person's personal risk is still small and very unlikely to manifest. But I do say that knowing that there is probably some risk, that probably the best thing we can do is to just avoid the things that we know we can avoid that alter your personal risk. And really, the one thing I think about is smoking, which, I think what I counsel people for is if they ask about, often it's mom and dads asking about what their kids' risks look like, and I usually like, are they smokers? Is usually my first question. And if they are, then I say, this is a pretty good reason to stop because that certainly is a modifiable risk that is important and really important if you have that risk. But in terms of that person's personal behavior otherwise and clinical screening, I think we don't have that answer. And I do think there's David Schwartz and Margaret Salisbury are both running studies prospectively to try to understand these questions. And we do refer people to that sometimes just for research purposes, but I don't think clinically we have any really insight beyond just, you know, be active, don't smoke, live as healthy life as you can.
Yeah. I think in 2025 that seems like a very good answer. The only thing I might add to that is clinically when I see family members that come with their patient family members is that they just need to be aware and potentially have that documented in their medical history with their other doctors so that if in the future something was uncovered or they began to have symptoms or something of concern that link could then be properly investigated. So great question. So now I'm going to iterate that just slightly and ask you to talk about somebody who has two or more family members that are affected by pulmonary fibrosis or interstitial lung disease and how they should approach their health prospectively going forward. And if there's any different action that you might advise them to take beyond healthy lifestyle and awareness.
Yeah, I think that's even harder to answer. I'd be interested in your thoughts too, but I mean, really, I think that to me is the most interesting population to think about for a clinical trial, which would be to understand what early intervention does and how that compares to just what we do now, which is sort of a watchful waiting approach. And in order to do that, though, we would need to do cross-sectional imaging with like a CT scan in those people, even in the absence of symptoms. And right now, there's really not a mechanism to do that or really a compelling clinical reason to do that in the absence of data that proves that it's a beneficial approach. Because screening can sometimes be harmful, even in our very best intentions. We can sometimes do screening and interventions that we think are going to help. And in some cases, that doesn't always help. Not everybody will progress, and sometimes using treatments in populations where some people were going to be fine, it just has downstream consequences that we can only measure in the setting of a randomized study. So I think, honestly, I think your point is, I think, most important for this question, which is to just really counsel that person about what symptoms to be aware of, what things to watch for. Obviously, all the same caveats about modifiable environmental risks, but what I would say is the rates of ILA progression that we see in that Vanderbilt study show that if somebody has early changes, it seems like it's going to get worse. And in somebody who has not had a CT scan, I'm not sure right now that there's a clinical indication to do it, but I would be very conscientious about what kind of symptoms to monitor for to try to identify it as early as possible.
Absolutely. I think that I land in a similar place on this. I've heard some very interesting back and forth discussions about the merits of trying to screen people who have risk, but if the amount of risk is not clearly known, that's a tough thing. To me, it just means that as a scientific and medical community, we need to do better in helping define this. And I think there's work being done, you mentioned, by several different groups at trying to understand this better. Okay, so one more question about genetic testing specifically, I've had several different versions of this question, but the point of genetic testing for both a patient and maybe a related family member, and I know genetic counseling itself is a little beyond what we're talking about right now, but needs to be integrated into that decision making. But what does it do from a management perspective for us in 2025? Is there any way to, beyond what we probably should be doing anyways, prevent or reduce the risk of family members or change the management of a patient.
Yeah, I mean, my impression is that even now in 2025, in terms of the management of the pulmonary fibrosis, regardless of etiology, that genetic testing has not shown any clear role for adjusting what we're going to do or how we're going to treat the lung manifestations of their disease. But as you sort of hinted at, I mean, there are familial cases where pulmonary fibrosis is only one of the manifestations. And so there are opportunities, I think, for especially familial cases to try to understand what the genetic link is for family members so that they can understand what other kinds of screening is required. So I think in those cases, it does probably make sense to see a geneticist and discover what other things they should look for. I don't know about your opinion, but my opinion as a pulmonologist is that genetic testing often is expensive for the patient and doesn't change the management that's available to me as of right now.
Yeah, I really value the input of genetic counseling for that matter so that we can understand a bit more about the ramifications for that individual. I certainly think that, tests are interesting, results are, especially from a research perspective, I think that gives us, tools for the potentially for the future, but really have to understand, and that is true of any test, what you're going to do with the results and what's going to change about that. I think genetic counseling can really help for an individual in particular, just like you're looking at, is it a more systemic problem? Is it something that may develop other types of problems in the future? And in that case, would somebody be more or less likely to pursue that? And what are the ramifications? I'm going to switch gears. I think this is a really interesting question. We had a few questions about the MUC5B promoter gene that you were talking about. I am curious on behalf of people I feel like might ask this question. We have so many questions at this point. I have lost track if anybody has asked it this specific way, but can a patient tell if they have this variant in the MUC5B promoter gene by the amount of mucus that they're coughing up? Because I know we typically think about a dry cough being, part of interstitial lung disease, but I certainly have my fair share of patients who have lots of mucus production. Is that really implicated in the MUC5B promoter gene change?
That's a really good question. It's interesting. As far as I'm aware, it's not. I mean, I think you're right. I think there's a various level of viscosity and sputum production that all of our patients have. And while they're not always just a dry cough, some have more of a productive cough. But as far as I'm aware, there's not any cross-sectional analyses that compare like the character and quality. My understanding of the biology, I'm not a mucus protein biologist, but my understanding is it has more to do with the disruption of balance between the MUC5B and the MUC5AC that may interrupt some of the function on a more like microscopic level. But also sometimes that may just be like hand wavy, meaning we don't really totally understand it. But my understanding is that it's not like people who have MUC5B are going to be just those who with a lot more productive cough, because certainly most IPF patients don't have that.
Absolutely. Yeah, I think that's what I was thinking you would probably say. But I'm sure that's something as you hear about the effect on mucus, like, oh, I must have it because
Yeah.
I cough up lots of mucus, and one could make that conclusion. But it seems a little bit more complicated and nuanced than that. Similarly, I've had some questions from around Sjogren's syndrome, which can cause dryness of the mucous membranes, and the interaction there with MUC5B. Are you aware of, and the answer could be no here, of any relationship between those two conditions?
Yeah, that's a good question. Interestingly, the scleroderma, which is probably more on the Sjogren's spectrum, it's one of the conditions that commonly causes ILD where we don't see that genetic association between MUC5B and the development of pulmonary fibrosis. We see it in RA and we see it in hypersensitivity pneumonitis, but in scleroderma, anyway, in some of the initial studies, it doesn't seem to have the same risk. So I don't know about Sjogren's. I don't know that anybody has looked at a population of Sjogren's disease because it's just more rare than the other two. But it's interesting to consider. It may be that a disease on that scleroderma spectrum might just be a slightly different underlying genetic risk than IPF and RA, which is maybe why they're less fibrotic patterns, but again, I don't know the answer to that. It's a really interesting question.
Yeah, thank you. That's helpful. I think so many unknowns and so many interesting things that could be studied here, and I think in many cases are um, that. Let's think. I have another question here, and now I've gotten lost in this very long list of questions that's coming
There's
in.
a lot
Thank
of
you guys
questions.
so much
Great.
for all of this. This
Yeah.
is wonderful. I'm going to try and get in at least one more. Um, Talk about testing for MUC5B. Let's go back. I think that was my next follow-on question. It is a common thing in the population, and so you were saying like it's implicated potentially in families, but also in sporadic risk. Is there any utility in testing for that in patients or non-patients?
Yeah, it's a good question. I mean, it's something I've we've been interested in how we might identify the most at-risk population for these kinds of screening trials. And I think one of the issues is because it's such a high penetrance in the population, it doesn't give us a lot of discrimination for who's really at risk. Most people who have it are not going to develop pulmonary fibrosis. And so you need to have a second way to enrich. Taking a population down to 10% is still way too massive of a population to expose to therapy for a screening trial. So then you need something else. And taking it from you know, whatever 2 trillion to 10% of that, it doesn't get us where we need to. Maybe in some of these subset populations like rheumatoid arthritis, where maybe if you could find the 10% of the RA population that has MUC5B, and that corresponds pretty closely to the number of patients that are going to clinically develop ILD, maybe there's role for it within the already enriched populations that are even at greater risk to begin with. That's kind of the place I think maybe. But again, we have to go from the maybe to a lot more, empiric data to get to that place.
Absolutely. Well, we are out of time. I have to do some additional housekeeping here. So if Scott, thank you so much, Dr. Matson. I really appreciate all these questions that you've answered. Before we close out today, I really would like to invite you to some upcoming events with our partner organizations. The PF Warriors is hosting a webinar this coming Saturday. The Scleroderma Research Foundation has a webinar coming up next week on September 16th, and this is information here. Next slide, please. We also have the Myositis Association hosting their MyoCon patient conference in Dallas, September 18th through 21st. And the Myositis Clinical Trial Consortium will also be celebrating World Myositis Day on September the 21st. Next slide. So many things happening. The Scleroderma Foundation of Greater Chicago will host a patient education conference in Chicago on October the 18th. And if you would, one more slide. The PFF Summit, the Pulmonary Fibrosis Foundation's biannual conference, is back this year, November 13th through 15th in Chicago. So if you want to scan the QR here, or you can visit our Pulmonary Fibrosis Foundation's website for more information and to register. Don't miss it, because if you do, it won't be back for 2 years. Finally, last slide, please. I'd like to thank the sponsors of the Pulmonary Fibrosis Foundation's Disease Education Webinar Series, Boehringer Ingelheim and Genentech. I'd like to also thank you again, Dr. Matson, for being here, for fielding so many questions and having such a great conversation about this really important but also really complicated topic, and breaking it down in a way I think people can begin to understand and wrap their heads around. And thank all of you for attending today. We're so appreciative. And please stay a moment, give us some feedback, and we'll see you at our next webinar. Have a great rest of your day.
Thanks.